This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello and welcome back. This is Justin Abbatemarco from the Cleveland Clinic, and again I'm joined by Valérie Biousse and Nancy Newman, reviewing all things related to non-arteritic anterior ischemic optic neuropathy. On today's episode, we're going to really talk about the management and its association with the GLP-1 medications. Valérie and Nancy, thanks again for coming back on.
Thanks very much.
Thank you.
The reality is we do not have an acute treatment for this disorder. Some people do treat with a baby aspirin. There is a very controversial topic regarding the use of high-dose oral steroids in these patients. I'd say it splits the neuro-ophthalmology community 50-50 down the middle. The background of this is the idea that perhaps oral steroids will reduce the disc edema enough that it'll keep this vicious cycle from happening. The only real study that looked at this is very flawed, and the neurologists among us know that treating acute cerebral infarctions with high-dose oral steroids actually doesn't help and may even be harmful. So where a lot of us are on the fence, Valérie and I come from the school that we do not routinely offer steroids to these patients. It's a lot of individual decision making because many patients cannot bear the idea that they can't be treated with anything and they want to try anything, even if they're a diabetic. And we know that the steroids are going to wreak havoc with their blood sugars. Often I take a middle of the road approach with these patients, lay it out for them, tell them that I usually do not recommend this, that the data are not good enough to support it, but I call in a prescription for them should they begin to have worsening of vision and they absolutely want to try something. And Valérie may have a different approach to this, but that is in general what I tend to do, and it's not based on science at all.
Yeah, I really try to push them away from steroids because I do not believe they do anything positive for these patients. I tell patients who have vascular risk factors, especially those who are diabetic, to not do it. But I always discuss it because the steroids are very strongly recommended by Dr. Google and the AI summary provided by Google when you search treatment of AION. And every patient who comes to us obviously has searched the treatment once they have heard of the disease. So it's important to mention it. We are neurologists, and we know that one of the things we do best in neurology is to not harm people. We are also very good at talking to patients about bad things. Many of the patients with acute vision loss present to optometrists and to ophthalmologists, and those who do not have any neuro-ophthalmology background are not prepared for this discussion. And they really want to prescribe something because it's a lot easier to prescribe a treatment, even a treatment that does not work, than to take the time to tell people that there is unfortunately not much we can do for them. And I'm not criticizing my ophthalmology colleagues, but that's when a neuro-ophthalmologist becomes handy.
These are really challenging conversations. And I know the other question that must come right up is, what's the risk in the other eye? How do you talk about that element when you're talking with patients about all these complications around treatments and prognosis?
The best data we have actually shows a lower risk than is often been shown in retrospective studies, which have been as high as 40% risk of second eye involvement. That's likely a number that may come with the unusual patient who is a young patient with NION because their optic nerve head is small and congested, that sure, if you're made the same way in both eyes, you would be at higher risk. It's actually about 15% chance of second eye involvement within 5 years. We don't have really good prospective data after that. This comes from the Ischemic Optic Neuropathy decompression trial, which had over 400 patients that were followed for that period of time. So that's pretty good data. We don't have good data that aspirin will stop that from happening, although there's never been a prospective trial to look to see if it helps. But if it's not contraindicated, we tend to do that. We do suggest that people have their obstructive sleep apnea treated and monitored, although there are patients who had the second eye happen while on CPAP. There is an old body of literature which has suggested that this disorder is precipitated in some way by having low blood pressure at night. And since people take their blood pressure medications before they go to bed, that they wake up with this. This was put forward by a very smart person in this field. And unfortunately, it's really been debunked, and people get taught this in residency and they bring it forward. In the Ischemic Optic Neuropathy decompression trial, where we saw patients within 2 weeks of onset of NAION, so they remembered when they had it happen. Indeed, about a third of them, so the biggest slice of the pie, said that they had it upon awakening. But if you divide the day up, and the natural way things are that people sleep about 8 hours a day, that would be about a third would wake up with it. And there was no specific indication around the clock otherwise. And I think it's very detrimental to start messing with people's blood pressure medication, which we now have some evidence that is better if you take it at night for every other reason. So I think this needs to be debunked.
Yeah, just one more little detail. The patients are devastated, okay? They have lost vision in one eye. We told them we have no treatment for that eye. If they are the lucky ones who kept relatively good central vision and just have a visual field defect, then we're in good shape, because we can tell them if it happens in your other eye, you will still be okay because you will still have central vision in your first affected eye. But if they have lost central vision, telling them you have 15% risk of having it happen in the other eye within the next 5 years, and there is nothing you can do to keep it from happening, is really difficult. So I never tell them that. I tell them it's difficult, and studies have suggested that you have 85% chance of not having any problem within the next 5 years and probably subsequently. And many of the patients who are not very good at math like this a lot better. And so that's my little advice. Always highlight the good thing, which is you had it in one eye, and once the disc edema has resolved, the vision will remain stable or slightly improve, but it will not continue to worsen. And the vast majority of people who had an AION in one eye will have it only once. It's one of the major reasons why we think the compartment syndrome plays a major role in the pathophysiology, because when you've lost 50% of your nerve fibers in your crowded optic nerve, well, you have twice as much room for those 50% who are still alive and healthy. And therefore, it does not happen again. So I tell people, the good news is it's not going to happen again in your first affected eye. It does not increase your systemic risk significantly of any cardiovascular disease or stroke in the brain. You have 85% chance of not having it in the other eye, and therefore, you're going to be okay.
I love that message of hope, right? How do we change that conversation to a more positive way? What I hear you talking about when we use that language of stroke with patients, right? We get the chance to talk about brain health measures like sleep apnea, high blood pressure management. How do we keep the brain and eye healthy moving forward? And so it does give us a little bit of an avenue to talk about those things in a more positive light so that patients can feel like they're being proactive. I know a theme that we've had now throughout the podcast was talking about medications. And you have mentioned two, amiodarone and these PD5 inhibitors. Maybe we could talk about the GLP-1. So you would discontinue these other medications, but can you talk about the relationship you would think through with the GLP-1s and their risk of AION?
This is one of the most hot topics of the last year and a half. And I'm happy to give in a nutshell what my thoughts are on, basically having reviewed the literature extensively. This is an issue in progress. As everybody knows, the GLP-1 receptor agonists are exploding in their use. if you only look at prescription information, we're talking about more than 40 million people in the U.S. having used these. That's 12% of the USA population. That doesn't talk about even the black market. There's a ginormous increase in its use since 2017. And we know the amazing benefits that it gives for a lot of neurologic diseases as well as systemic disorders and weight loss. These are game changers, these drugs. And what started this conversation with NAION was a publication in late 2024 from the Harvard group, Hathaway et al., who had noticed anecdotally that they seemed to have a lot of people show up with NAION who were on these GLP-1 RAs. And it seemed more than what they had seen. It's a single center. It has a lot of issues, but it's a good study to get this conversation started. And what they did is they looked at each case of NAION that they have, and they manually confirmed the diagnosis, which we'll see big data can't do that. And they compared the incidence of NAION cases in those patients prescribed semaglutide, which was one of the first of these agents to be approved. So what they did is they looked at the incidence of NAION in patients who had been prescribed semaglutide, and they did confirm that the drug had been dispensed, but they can't confirm that it was actually taken, versus those patients who were on another treatment for diabetes or another treatment for obesity. And they did separate analyses of those patients who had type 2 diabetes versus those patients who had obesity. And it was a remarkable difference. The risk of NAION was greater than 4 times greater in the diabetes patients who were on semaglutide, and was greater than 7 times more frequent in those patients on semaglutide who were overweight or obese and taking it for that reason. And this really, as you can imagine, blew things open. Now, I will say that the actual risk was still exquisitely small. This disorder, NAION, is uncommon. And even though there was this greater risk, it was still very infrequent in those patients, even on semaglutide. So the strengths of the study were this manual confirmation chart review of the diagnosis of NAION, and the higher risk in the obesity patients might actually reflect the fact that larger doses of this drug are used when you treat obesity versus when you treat diabetes. But single neuro-op institution with referral bias, relatively small numbers of patients. And is this population comparable to most users of GLP-1 RAs? Remember, we're dealing with Boston and a nearly all-white population. And initially, they also had no matching for the severity of the confounders. They matched for confounders like, did this person have hypertension, etc. Later on, and they presented this at Nanos, it has not been published yet, but it was presented. They actually did look at the severity of the BMI in the cohorts, the severity of the hemoglobin A1C levels, and the difference in cup to disc ratios. And there really weren't any significant differences between the groups, suggesting that those confounders were not really confounding. But what this triggered was an enormous amount of publications. I think we're up to over 40 now, some which have suggested that GLP-1 receptor agonists are associated with a higher risk of NAION. And again, remember, we're not dealing with causation here. We're just associations. And others that have suggested that they're not associated with a higher risk of NAION. And some with an association, some without an association have occurred even with meta-analyses. And what is truly remarkable is that some have found it using the same database, because most of these are done with ICT 10 code searches and large databases used, and we have one article that suggests they are associated, another article that suggests they're not associated. What does it come down to? After really reviewing this, I do think there is some association, but it is nowhere near the magnitude of what was first reported in Hathaway. I think it's probably somewhere just under 2 times the risk. And again, if you think about how rare this disorder is, then by the numbers, we are talking about a very small number of patients.
And I really appreciate the deep dive on this. I think it then raises the question, right? You feel like you're caught between a rock and a hard place, that there's a potential relationship with an incredible class of medications. And then you have an event that's tied to their vascular risk factors. Like, how do you counsel patients then? We talked about discontinuing the other medications that have been associated with non-arteritic anterior ischemic optic neuropathy. How do you talk about this with patients?
So the others, you think about, in some ways, the PDE5 inhibitors, they're a personal choice. The amiodarone, if the cardiologist can do an ablation or can pick another medication, a reasonable choice. We also don't know if it's causative. No one has come up with any idea of what the proposed mechanism might very well be. And you can imagine this has become potentially a medical legal issue. The European Medicine Agency, which is the equivalent of the FDA over in Europe, has actually indicated that the medication should be stopped if you have a patient on it with NAION. The North American Neuro-Ophthalmology Society and the American Academy of Ophthalmology has not agreed with that statement. They feel it has to be a discussion with shared information and shared care amongst all this patient's providers. It's very hard. I think that as a neurologist, as a neuro-ophthalmologist, as an ophthalmologist, you must discuss it with the patient. You must discuss it and communicate the situation to the patient's primary provider who has made the diagnosis of whatever the reason that patient is on this, one of these agents, who knows that patient and that patient's health and what the risks and benefits of that medication are. This is a very difficult conversation, and it's especially difficult in those patients who ask, what about my other eye risk? And for those people who have not yet had an NAION while on GLP-1 receptor agonist, but had one before they were started on the medication. Should they stop it? Those people presumably are even at greater risk for having NAION, and we don't have the information on what that risk is. The one thing we would suggest is that please do not send all your patients who are about to be started on a GLP-1 receptor agonist to be screened for whether they have a small cup-to-dis ratio or not. We've estimated that at least 12% of the U.S. population have a small cup-to-dis ratio. I'm not sure we would be helpful regarding this issue.
The diagnosis of AION is essentially a clinical diagnosis. It's based on vision loss in one eye, it's related to an optic neuropathy, and there is disc edema, and there is a small cup-to-disc ratio in the other eye. The MRI of the orbits does not show optic nerve enhancement. The patient did not complain of pain with eye movements, and therefore it is not an optic neuritis. It is not inflammatory. Very often, patients with AION are diagnosed by eye care providers and neurologists as having optic neuritis. And they receive a brain MRI, which quite often will show non-specific white matter changes. And with the recent publication of the new McDonald criteria for diagnosis of multiple sclerosis, a number of those patients are going to end up being diagnosed as multiple sclerosis because optic neuritis is one of the criteria now included in those diagnostic criteria. And so I would like to make sure that everybody keeps in mind that optic neuritis and AION are two very different optic neuropathies, and that making the right clinical diagnosis is absolutely essential. When a neurologist makes a diagnosis of optic neuritis, unless it is completely obvious and definitely confirmed by the orbital MRI, which shows optic nerve enhancement, you should involve a neuro-ophthalmologist prior to prescribing any neuroimmunologic treatment to those patients with isolated optic neuropathies.
It's so difficult to navigate now. But this at least gives us some construct, some ways to interpret, again, only retrospective data that we have so far. And we can come to patients being a little bit more informed. And then again, I think going back to the beginning of your talk, confidence around this diagnosis and tools that we can employ to make sure that we're thinking through this correctly. So with that, I just can't thank you enough for your time to come back on and talk about a really controversial entity that spans this ophthalmology, neurology world and help us better understand it. It is so helpful. I know you've challenged my thought process and it's going to change the way I approach care, and I'm sure for others. So thank you.
Thank you, Justin.
Thank you very much.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.